Hello everybody, this is Dr. Medicine RX, and in today's video we'll be talking about cryoglobulinemic vasculitis or cryoglobulinemia for that matter. So, cryoglobulinemic vasculitis is a type of small vessel vasculitis which is characterized by the presence of cryoglobulins. So, cryoglobulins are abnormal immunoglobulins that undergo reversible precipitation at lower temperatures. So before we enter into the actual topic, there's a need to understand some basic terms. First is precipitation. Precipitation essentially means that the immunoglobulin, it freezes or becomes a solid. Then there's rheumatoid factor. Rheumatoid factor does not necessarily mean that the patient has rheumatoid arthritis. It is just an immunoglobulin that is formed against Fc portion of other immunoglobulins. And then we've got monoclonal and polyclonal immunoglobulins. Monoclonal immunoglobulins are immunoglobulins that are formed against single epitope of an antigen, whereas polyclonal immunoglobulins are those that are formed against different epitopes of a same antigen. So a single antigen is capable of producing different types of immunoglobulins. And then there's the basic pathogenetic mechanism behind cryoglobulinemia, that is immune complex formation. So coming to the types of cryoglobulinemia, we've got three types: type 1, type 2 and type 3. Type 2 and 3 are together called as mixed cryoglobulinemia. Type 1 is that there is formation of monoclonal antibodies. So we've got IgM and IgG types, where IgM type is most common, and these antibodies, they cause vascular occlusion and produce the features of vascular occlusion. This is most commonly associated with lymphoproliferative disorders and some plasma cell diseases. And then we've got type 2 cryoglobulinemia, wherein there is formation of monoclonal IgM antibodies against polyclonal IgG antibodies. So here you can say that monoclonal IgM antibodies are rheumatoid factor. And then in type 3, we've got polyclonal IgM antibodies forming against polyclonal IgG antibodies. So different types of IgG antibodies are capable of producing different types of IgMs which are acting as a rheumatoid factor. So these mixed cryoglobulinemias, they produce vasculitis and are commonly associated with infections. In these infections, we've got HCV, HBV and sometimes HIV as well. But HCV is associated with 80% of the cases, followed by HBV. It can also occur in association with some connective tissue diseases such as systemic lupus erythematosus, Sjogren syndrome, etc. and also sometimes with lymphoproliferative disorders. So, cryoglobulinemia is most commonly seen in females. We've got male is to female ratio of 1:3 or female is to male ratio of 3:1, and it is commonly seen in the age group of 40 to 60 years. It can also occur in children, but it is very rare. Then coming to the vaso-occlusive features that are commonly seen in the type 1 cryoglobulinemia, we've got acrocyanosis, Raynaud's phenomenon, gangrene, purpura and retinal hemorrhages. Here we've got more cutaneous features. Whereas in type 2 and type 3 mixed cryoglobulinemias, along with vasculitic features, we've also got systemic manifestations. So along with cutaneous vasculitis, which can present as purpura or erythematous macules, we've also got systemic manifestations such as arthralgia and arthritis, seen in about 70% of the cases. Renal glomerulonephritis, that is membranoproliferative glomerulonephritis, seen in about 25% of the cases. Peripheral neuropathy, seen in about 40% of the cases. Hepatitis and GIT disease, which is seen in some of the cases but not as quite common. This hepatitis, mind you, it can be because of pre-existing HCV and HBV infection, or it can be a result of the systemic manifestation of the cryoglobulinemia. Next, we're coming to some of the other clinical features. We've got the classic Melzer triad, which is characterized by purpura, arthralgia and weakness. I've given the mnemonic of PA. The purpura is palpable, but it is not usually the case. You can also see in the form of erythematous macules, ecchymosis, bullae, ulcerations, livedo reticularis. Sometimes you've got nail fold capillary abnormalities, digital skin necrosis and cold urticaria. These features, they are usually seen in dependent parts of the body, that is commonly the lower limbs. Then arthralgia and weakness. Arthralgia is usually also associated with arthritis. It is seen in proximal interphalangeal joints and also metacarpophalangeal joints, followed by the knees and ankles. Other some lesser important features, we've got fever, weight loss and fatigue. Next, coming to the investigations, here we have to remember that cryoglobulinemia is a small vessel vasculitis, and the primary investigation is that you need to detect the presence of cryoglobulin in the given blood sample. For this, you have to collect the blood in warm tubes, and you have to see that the temperature is maintained at 37 degrees centigrade in order to avoid the precipitation, and also while being transported, the temperature should be maintained at 37 degrees centigrade. This is followed by centrifugations, and then there's lowering of temperatures, allowing them to precipitate, and then you determine the cryocrit value. You have to see that you don't add any anticoagulants after collecting the sample, and the cryocrit value is usually close to 0 in normal people. And for different types of cryoglobulinias, the cryocrit value starts from 0.5, and then there's a range. Then there's also spectrophotometric analysis of the cryoglobulins. You can do urine analysis, and then the serum complement level detection, where you usually see hypocomplementemia, and especially the C4 levels are low. Then RF factor positivity is seen in type 2 and type 3, because we've got different types of clonal antibodies forming against different types of clonal antibodies, and of course the erythrocyte sedimentation rate is raised. Then you can also do viral serology to detect HBV and HCV infections, LFT, anti-nuclear antibodies for connective tissue diseases. Then you can also do serum protein electrophoresis. Next, skin biopsy is a really important investigation, wherein on the histopathological image you see leukocytoclastic vasculitis, that is neutrophils show leukocytoclasia, that is there's karyorrhexis, there's nuclear fragmentation, and there's also immunocomplex deposits which are POS positive and are seen as globular deposits. And then in chronic cases you can also see mononuclear infiltrate. Other organ biopsy we can do for those organs that are involved, such as kidney, lungs, and muscles. We can also do an EMG. Coming to management, so essentially here you have to see that the immune complex levels are reduced. This you can do by immunosuppression or by plasmapheresis. Immunosuppressions are primary immunosuppression agents, that are corticosteroids. We start with them, and if there's an HCV infection, we give pegylated interferon alpha along with ribavirin. If it is not responsive to this treatment, we can also go for rituximab. Then if there's any underlying lymphoproliferative disease or any other malignancy, you have to treat that. And for HBV infection, there have been some positive results with entecavir. And if there's no response even with large doses of corticosteroids and rituximab, you can go for cyclophosphamide, which is a very great steroid sparing agent. Of course, for later stages of diseases, we can do plasma exchanges, or we can go with other immunosuppressive agents. Well, thank you for watching this video on cryoglobulinemic vasculitis, and for more such crisp content, do subscribe to Dr. Medicine RX. Bye bye.